Hello again, Christine. Ready to talk about neuropathologies?
Yes, I am ready.
I think we've got somewhere around 13 pathologies to cover. Now, I've seen a bunch of different neurological conditions in my career. I know you have a lot of experience in the neuro world. What kind of experience are you pulling from to help us understand this stuff?
So I've worked in subacute rehab, and there was a lot of stroke there. And then mainly in community-based occupational therapy for traumatic brain injury. So a lot of work with brain injury in general.
Nice.
Yeah.
All right, well, let's get started. We'll get started with our peripheral nerve injuries. So damage to peripheral nerves can be either reversible or irreversible, depending on the severity of the injury and also the duration in which it lasted for. Three main classifications of peripheral nerve injuries: neuropraxia, temporary damage to the nerve caused by to pressure to the axon; no structural damage, does not cause muscle atrophy, may result in temporary paralysis, but will resolve quickly. I think of this as I'm leaning with my elbow driving, and all of a sudden my hands goes to sleep, and then sometimes if it's severe enough that you can have trouble moving different muscles, and I'm thinking in my hand the times it happens to me. Axonomesis, prolonged pressure on the nerve causing a more serious injury to the axon. The neural sheath remains intact, and the axon may regenerate at a rate roughly 1 millimeter per day. But there's a chance it won't. So there's a lot of different factors. Then some of it's just luck. A lot of it's the age and nutrition level of the patient, but luck plays a lot to do with that. Will result in atrophy to the muscles and, again, potentially paralysis. So this one we have to really be hopeful and really rely on our neurosurgeons to help guide us into the prognosis of people. And the neuromysis is both the axon and the axon sheath are damaged. If the axon regrows, it doesn't have a path to follow, and that's where the problem is. If it is going to regrow, it doesn't know where to go, so it's not going to combine back to its partner on the other side of the injury. So surgery might help facilitate this regrowth, but it could be just a long-lasting injury.
And being familiar with these terms can help you to look at what type of intervention, because you'd have a better idea of what the impact of the intervention that you're choosing.
Yeah. So typically it's a result of compression, chronic inflammation, tumor, or other space occupying lesion. If it's compression of the nerve as it exits the spinal anatomy, the intervertebral neuroforamen, it's called a radiculopathy. And because nerve and blood vessels are usually linked right next to one another, then ischemia may also be a result of that compression. The most common ones is carpal tunnel, mostly with typing type injuries, resting your hands on a keyboard or a desk to type. That's a really common one. And then one thing we have to be careful of, especially when our patients start learning how to use assist devices like axillary crutches, we have a crutch palsy where the axillary nerve gets compressed because, as you can see, this woman, she's regretting her choice in physical therapist and physical therapist assistant because they malfitted the crutch to her. We need a space in between the axilla and the top of that crutch pad. We need at least 4 finger breadths for that. And it's important to teach our patients not to lean on that because we have risk of these compression injuries.
And another point with the nerve injuries is a lot of the time we'll see patients that are having pain, and the process to get to a diagnosis to know specifically what we're treating can take some time, and a lot of what we're observing and what we're documenting and what we're reporting to the doctors can help clue them in on what might be the challenge. So what are some of the signs that have led you to believe that it might be a nerve injury causing pain in practice if it wasn't certain based on the diagnosis?
Well, because they're so slow to regenerate, the symptoms can linger a lot longer than what any other musculoskeletal type injury I would expect. So that's one big clue. But also just the descriptive words that the patient uses for describing what their pain feels like. Numbness, tingling, burning, my hand fell asleep. Those type of keywords help us think it's more of a nerve related problem than otherwise. And sometimes this happens, somebody breaks their lower leg and gets put in a cast. Well, sometimes that cast is poorly fitted, and that cast is now compressing on a nerve. So once their original pain of their broken leg subsides, now the person is getting all of these other types of pains, and it's different than the acute pain of that initial injury. So yeah, usually those keywords would help us. All right, next up, we'll talk about our traumatic brain injuries. So mechanisms of brain injury can be anything from skull fractures, a hemorrhage, which is a bleeding event, edema, or direct injury to the brain tissue itself. A lot of different terms that can be used to describe head injuries, concussions, contusions. Types of fractures include closed, open, linear, commuted, compound, or depressed. Those are odd looking to see because it's just a piece of the skull just has a big dent in it. We have basilar and contracoup. So contracoup is one interesting one that I want to spend some time with. Area of the brain injury that occurs when an area of the brain is injured contralateral to the side of impact. So what happens with this is basically like I can get hit in my forehead, and that impact can cause injury to my frontal lobe. But as I whip my head, momentum brings my head back, and as I whip it back forward, and the back part, my skull is basically being accelerated into my brain. So now I'm going to have a brain injury on the posterior side, even though it was an anterior side impact. So yeah, it can be contralateral sides as well. Basically, the skull is being accelerated into the brain with this type of an injury.
And so you can have lesions in multiple areas of the brain.
Right.
And that can impact function in different ways. And then this would be common with, for example, car accidents where the seatbelt's holding you back. And so you have that sort of whiplash.
Absolutely. And even side impacts, having your head jostled side to side, definitely.
And then there's also, I don't know if it's still called this, but shaken baby syndrome, where people learned, not to pick up a baby and shake it, because that can lead to this type of injury.
Yeah, we're going to touch on that in just a little bit. So any trauma to the brain tissue that causes loss of function to the body part that's controlled of the brain. So that is what a brain injury is defined as. Primary brain injuries, direct injuries to the neurons, glial cells, or blood vessels of the brain. Could be lacerations, compressions of brain tissue, foreign object or compression or rupture of the blood vessels. Secondary brain injuries are from additional effects of cerebral edema, hemorrhage, hematoma, vasospasm, infection, ischemia from systemic factors. So the brain injury is the second problem. It's the result of whatever else happened, right? We had some sort of massive infection, and then the brain became damaged because of that infection. So it's easy to think of brain injuries as the direct impact that, like we were just talking about, but it's not. The secondary ones can be from a whole host of different problems.
You can get a brain injury from a heart attack.
Yeah. So one other, just to kind of anatomy that you could see brain injuries defined as is the exact location of whatever their hematoma or hemorrhages, either swelling or bleeding. So epidural, subdural, or subarachnoid, just referring to the meninges of the brain and talking about exactly where was this problem. Intracerebral is in the cerebrum itself. And a big problem with all of these hematomas, it causes increase in local pressure and increased intracranial pressure, ICP. And now that increased intracranial pressure is now compressing a whole host of brain tissue, and that can cause a wide range of problems. So reducing the amount of pressure is the number one problem of the number one treatment that they're going to do once we first start going to the hospital for these type of injuries, is reducing that pressure however they can. Medication, surgeries, whatever. We'll talk about that in a little bit. So etiology of brain injuries. Most brain injuries occur in young adults, males more frequently than females, result of sports injuries, motor vehicle or motorcycle accidents, and violence. Excessive alcohol intake is also a contributing factor. A lot of reasons for that. Decreased coordination, decreased judgment, other reasons for that. And what the problem with that is, when someone rolls to the hospital with a brain injury and the team is starting to look at neural deficits, well, the alcohol, is this deficit because of the alcohol they've ingested, or is it because of the brain injury? So it makes it really tough for that staff to figure out exactly the severity of the problem initially.
And there can also be alcohol withdrawal can lead to brain injury as well.
Yeah.
So there's certain protocols that they'll use at the hospital to try to prevent brain injury, to support people who are going through alcohol withdrawal.
Interesting. So again, most injuries occur in young adults, and the other most common one is in older adults when a fall causes a brain injury. And I've had plenty of patients fall and get a brain injury because of that. Mm-hmm. And like you were saying earlier, in infants, violent shaking can cause that brain injury as well. So signs and symptoms. So we can have focal signs. So a specific area of the brain is injured, and we'll start seeing those focal signs. So, some sort of injury to the occipital lobe is causing the person starts complaining of visual changes to it. We might see some personality or judgment disorders after a frontal lobe. So we can also see generalized signs, kind of everything's awry, with an increase in intracranial pressure, the ICP, nausea, headache, confusion, increased blood pressure. Person might also develop seizures, cranial nerve impairment, autourea or rhinorrhea, that's leaking of the cerebral spinal fluid from the ear or nose. So when someone has a traumatic brain injury and they start doing that, that is a big risk of microbes now entering the brain. So that is a huge risk of infection now. So kind of a double whammy. Fever, secondary impairments from prolonged immobility, such as pneumonia or developing pressure ulcers, can also happen.
And with the intracranial pressure, you don't see right away the extent of the damage from the brain injury. You have to give it time to let that pressure be reduced to really see how the function is impacted over time.
Right. Treatment, first of all, imaging and testing to look at the extent of injury. Lots of medications aim to decrease edema. Glucocorticoids are the first ones, and also to reduce effects of infection, so antibiotics. Surgery to reduce intracranial pressure. Sometimes they'll just remove a piece of the skull just to relieve that pressure, and then they'll put it back later. Different blood products and oxygen to the damaged tissue, try to reduce the damaging effects of decreased blood or oxygen. Frequent monitoring for neurological signs. So looking at, the person, are they oriented to person, place, and time are the big things. Do you know who you are? Do you know where you are? What is the date? Pupil size and reaction to light, change in behavior, headache, and also irritability. Now, that means irritability of not only the person's mood, but also irritability of the nervous system itself. So, headache from bright lights is the nervous system is now irritated by that environmental factor, loud noises, things like that. So that it's not just mood. I know when I first started studying this stuff, I said, why would somebody be irritated if they had this? No, it's kind of encompassing nervous system irritability.
Mm-hmm.
So what are we going to do in the rehab medicine, massage, PT, OT? How are we going to help people recover from brain injuries? The big, broadly speaking, is improve overall mobility, address the specific motor, visual, and cognitive impairments, education to understand from not only to our patients, but also to their family members that impairments might resolve, but there might be things that are also permanent as well. And, that's just broadly speaking, but like we talked about, do the different lobes of the brain matter? So an injury to this section of the brain is going to require a different treatment approach than a different section. Do you have any other ideas on the treatments?
So many. So if I think about it in terms of the sort of sequence of response and settings that a person would see massage therapy or physical therapy or occupational therapy, in acute care after a brain injury, it may be positioning or coming up with ways to try, maybe they're in a coma for a little while. And so it could be to preserve their function and positioning their body in a way that they're not going to get pressure ulcers or things like that. When they're out of a coma, maybe it has to do with impulsive movements and trying to prevent like pulling out IVs and things like that. Then it might go to now they're ready, sometimes having to learn how to feed themselves again or walking again, building up if they had some muscle atrophy at that time, but just working on coordinating the movement and having the brain heal, because the brain can heal. There's neuroplasticity. So that's being able to have the messages sent using different pathways. And that's what we're working on when people are relearning how to do certain things. There's a lot of different approaches that can be used. I primarily practiced in community-based brain injury. So this is well after the healing has happened. They've basically regained the amount of function that they're going to gain. And then what we would look at is maybe playing different types of brain games to work on those, the neuroplasticity and having the messages sent through different pathways. Another intervention that we've done is sometimes people who have brain injury will present, like if there's maybe a situation where they might look suspicious and law enforcement might approach them and they may have challenges with communicating. Maybe they're slow to communicate. Maybe they're not clear when they speak. Maybe the way that they walk might look suspicious or they aren't making eye contact, things like that. So creating wallet cards so that if a person needs to be able to communicate, I have a brain injury, this is the best way to support me, like allow time for my response, things like that. So there are a lot of different approaches that you can use, maybe with supporting people for learning strategies around their impulse control or their safety, things like that.
We could really spend a whole semester talking about each lobe of the brain. What are the treatment strategies for this specific lobe versus that one? Short term, immediate, short term, moderate term, and long term. what is their functional? Yeah, we could spend so much time with this. I think you gave some great ideas for us just to get our brain started, though. Thank you. So next up, we'll talk about injury to the brain, a cerebral vascular accident, also known as a CVA or a stroke. A stroke will occur every 40 seconds, hopefully not to either one of us in the next few minutes, but a stroke will happen in the US every 40 seconds. About 800,000 people have a stroke each year. 610,000 are first-time strokes. So, there's a decent amount of people that are having these multiple strokes in their lifetime. 1/6 of cardiovascular deaths are because of a stroke, and the incidence increase with age. Most of the strokes happen in adults over the age of 65. So the pathophysiology of it, well, a stroke is an infarction or obstruction of blood supply in the brain. That lack of blood supply causes ischemia, which is just a lack of oxygen, which causes tissue death. The irreversible nerve damage in the brain can occur in as little as 5 minutes. And there's three most common ones. First two are examples of an ischemic problem where there's less blood supply, and the other is a hemorrhage. So the most common is a gradual occlusion of the artery, most commonly the carotid arteries, by plaque and thrombus, leading to TIAs, which is a transient ischemic attack, sometimes called a mini stroke. And then eventually it leads to a bigger stroke down the road if it's not resolved. Typically, the effects are localized to a specific area of the brain. So this is, again, there's the artery is becoming more and more narrow and delivering less and less blood supply. Now, there can be a sudden obstruction from an embolus. So that's a small piece of plaque or a different matter of blood clot breaks off, breaks free, and then lodges in one of the small arteries of the brain. Now, this acts as just a big shutoff. Now there's no blood supply can pass that. Again, the effects of this are typically localized as well. And then the other form that we can have, the category is a hemorrhage. That's a rupture of the blood supply. So some sort of cerebral artery, patients most of the time with severe hypertension, the artery just can't withstand that amount of pressure anymore, and it bursts, and now we have a bleeding event. Now, these type of strokes are typically widespread and severe. So interesting to see the different severities just depending on the different mechanisms of the injury. So some of the risk factors include diabetes, high blood pressure, systemic lupus, elevated cholesterols, hyperlipidemia, atherosclerosis. And one thing I didn't understand, I didn't know this off the top of my head, atherosclerosis, use of oral contraceptives and smoking are risks of developing atherosclerosis. So I didn't know that about the oral contraceptives. History of TIAs, again, we call that a warning sign or mini strokes. That's a risk factor of developing more severe stroke. Increasing age, obstructive sleep apnea, and heart disease are all risk factors for strokes there.
That's a good choice of image for that slide.
You did a great job picking out the pictures. Nice job.
I was trying to compliment you.
So signs and symptoms, first think fast, face, arm, speech, and time. Someone's face just starts drooping or becomes non-responsive. Their arm may become limp. Their speech becomes slurred, and then time is we have to act fast to reverse the effects of the stroke.
Why is it helpful to act fast?
Because we get to restore the blood flow as fast as possible to prevent further damage.
And with certain types of stroke, there's medications that can be given to prevent as much damage.
Yeah, especially in the ischemic type strokes, if there's a blood clot, boom, we can deliver these powerful clot busters, and they can work within minutes. So yeah, the faster we act, the less damage that person's going to have.
An example too of this using fast is face. I would ask somebody to give me a big smile.
Yeah.
If the smile was lopsided, or you would be able to tell if they were only smiling with one side.
Right.
That would be something to be very concerned about. Ask someone to raise their arms up and maybe they're only raising one side.
Yep.
And then just paying attention to their speech.
Yeah. So residual signs and symptoms depends on the exact area of injury within the brain. Again, we've talked about different lobes of the brain, different areas of the brain, and yes, the blood supply as well. Whatever area of the brain that has the injury is going to have a specific set of signs to it. So initially, if there is a body involvement with it, initially you can have flaccid paralysis, where basically the limb is just attached to the person but will not move. Someone could come around and pick up their limb and it would immediately flop down. So that's flaccid paralysis. Eventually, after a few weeks later, the spastic paralysis, which we have a little picture of, that's the classic spastic paralysis maneuver, that flexion spasticity. So still no voluntary movement can really happen with this, but they have a high tone and they're stuck with this spastic movement there. Some physical symptoms present on the body contralateral to the side of the brain injuries. So again, a right brain injury would cause left body impairments. Something else that's interesting, a right brain injury will lead to left side neglect more frequently. Left side neglect, where a person does not acknowledge that they have a left side of their body. Fascinating to work with. Big safety concern if they start using a wheelchair for locomotion. Even in the hospital setting, when we transfer somebody to the wheelchair, if their arm is hanging off the side of the wheelchair, the patient doesn't know that arm is existing, and it might get caught up in the spokes of the wheelchair without the patient ever thinking they even have a left arm. And a left brain injury is going to help create more speech impairments, either Wernicke's or Broca's type aphasias too. Now, what other information do you have on the sides of the brain, and what kind of symptoms might it present with as well?
Yeah, a couple of things. So if I'm doing a chart review for a patient and I see that their stroke was in the left hemisphere, then that sometimes can be an indicator of it's more likely for them to have a post-stroke depression. So from an occupational therapy standpoint, we can look at working on motivation and hopefulness, trying to work on motivation and hopefulness to help support their working toward becoming more independent. Because I've come across a lot of patients who had a left hemisphere lesion, and they kind of just are the patients who just want to give up. They can't believe this happened to them. But then a right hemisphere injury, they're more likely to be like, what do I need to do to get better? And so if you can kind of predict that you may have to address getting them motivated first, that can be a barrier for them. Something else, just looking at the paralysis in terms of interventions. So for flaccid paralysis, we may use a sling for a little while to prevent them from having their arm dislocated. Why am I blanking on the word?
The sublux, is that the
subluxation? I don't know why I forgot that word, but to prevent a subluxation. And then the spastic paralysis. So if you look at that image, to me, there's so much potential for massage therapy and occupational therapy, especially that flexor synergy pattern. So this is where everything wants to flex with the spasticity. So we would want to, maybe if it was an older injury, you can get infections between the fingers. And it's really difficult if the person's dependent on others to bathe and dress them. It's hard to dress someone when they're like this. So you want to prevent this from happening. So you can prevent that with different types of splints, with passive and active range of motion, and having a splint to splint them to prevent this from eventually happening. There's certain types of splints that can kind of open up their grasp to prevent them going into that flexor synergy pattern, which they'll get contracted and can't come out of.
Yeah. Yeah, no, I mean, with massage, there's so many tone reducing types of massage that we can do. And maybe it'll help really for a long time, or maybe just for today in the acute setting. Maybe there's a timing of, hey, massage, what time are you going to go see with this person? Okay, you're going to reduce their tone, and then I can get in there immediately, start working on this stuff. So there's an opportunity for a big team approach. There's a lot of conditions where a good team approach is always going to help for anybody, but I think for stroke, there should be so much communication and so much overlap and so much brainstorming that happens within the team, because we can really amplify one another's treatments.
Yeah, absolutely.
Send you in first thing in the morning to motivate them, and then I'll go in after.
Yeah, then the massage therapist will go in and loosen up that tone, and you'll go in and do the range of motion, and then I'll go in and put the splint.
Perfect.
Love it. We'll all do education with the caregivers.
So again, more treatment stuff. I know we kind of just already started talking about that, but rapid clot busting medications initially, if it's not a hemorrhage type stroke, potentially surgery, different medications to reduce edema, supportive treatments like oxygen therapy should they be needed, treating the underlying conditions that cause the stroke. So high blood pressure, the example of that one. For us, I mean, it's in the rehabilitation medicine, it's like we talked about with traumatic brain injuries, mastering bed mobility first. Then can we get to seated at the edge of the bed? Can we get seated to standing? Can we minimize the deficits long term? Can we reduce some of those problems already? Can we hedge that off? That neuroplasticity is a really interesting concept that if people are interested in the neuro world, they should really seek more information about that, because yes, once this brain tissue is injured enough, it's not going to regrow, but the path, we can create a new path for that message. So maybe a person will learn how to walk again, but they're going to learn to walk differently than what they were. And that's and that's for all of the tasks that we have for ourselves. So yeah, it's just because we're not going to do it the same doesn't mean we're not going to do it again.
Right.
So it's a really fascinating topic to dive into. And now, go ahead.
In terms of rehab approaches, it's important to recognize that therapists may be coming across a person who's had a stroke at different parts of their journey. And so sometimes it is right after the stroke, you're in a more acute or subacute rehab setting, and there's more that you can do in terms of a rehabilitative approach. But then if you're coming across someone later, maybe you're seeing them in home care for some other type of diagnosis, but they have had a stroke in the past, so you have to consider that. With occupational therapy specifically, we look at, are we taking a more of a rehabilitative approach? So we want to figure out how to get this person to do this thing again, just like how they used to do it. And sometimes that just is taking time for healing. But then there's a compensatory approach. So do they still do the task, but they just do it slightly differently? So now instead of writing with their right hand, we're going to teach them how to write with their left hand. Or there's an adaptive approach where maybe they don't have grasp as much as they used to be able to manage utensils when they're feeding themselves. So an adaptive approach would use equipment to adapt how they do the task. So maybe they have Velcro around the utensil to help them hold on to it so that they can now hold on to the utensil to feed themselves. So there's different approaches depending on what the chances are that the person would be able to improve in that area.
I think it's a great point to make. Yeah. Sometimes we're looking to regain a bunch of stuff right away. And other times we say, okay, how can we adapt around this problem? Yeah. Mm-hmm. Yeah. Now, complete recovery, our textbook says is rare. But sometimes the recovery is so great that the residual symptoms are barely perceptible. But the sooner the rehab begins, the more optimistic the prognosis we can have. But unfortunately, roughly 20% of people with a stroke will die within the first few days after their stroke. So it is still a really devastating problem to have. Different type of brain injury would be cerebral palsy. So cerebral palsy is a brain injury that occurs during or shortly after birth. It's non-progressive, and by definition, it has some degree of motor impairment. About 10,000 new cases per year, roughly 500,000 people in the United States have cerebral palsy. And the injury of the brain can be from a lot of different factors. So any altered brain tissue, either by malformation, mechanical trauma, hypoxia, hemorrhage, hypoglycemia, infection, or other mechanics causing that cellular death, necrosis. So this is to the infant, either as they're developing as a fetus or once they're shortly after birth, it counts as well.
During the birthing process, like if the umbilical cord is wrapped around the neck, things like that.
Yeah, common one for that. Yep. All children with cerebral palsy have some sort of degree of altered mobility, but because we're talking about the brain, it can also have a whole host of other different problems, just depending on the exact area of the injury. And again, that's why that anatomy knowledge of the overall lobes of the brain and the functions and jobs of them is really important to understand. So the symptoms can be present at birth, or they might not be apparent for several months later. Delayed motor development, abnormal muscle tone, and the persistence of early reflexes are the ones that typically we start seeing. And I know I have 2 kids, and whenever I go to the pediatrician for their routine physicals, the docs are always doing all sorts of tests to test reflexes, and some of them we should grow out of quickly, some of them will develop later on, and that's what those docs are always checking, is the normal neural development happening. The Moro reflex, startle reflex, holding on to that one is an early sign. So that's where, especially, it's more often than just sleep, although it always irritated me with sleep, because when the kid's just about to fall asleep, finally, after crying for all of those hours, then all of a sudden they startle awake over what seems to be nothing. That's the Moro reflex. If we wanted to, we could find YouTube videos of all these infant reflexes. Some of them are really funny. Some of them are really cute. So feel free to, on the student's own times, go ahead and go down the rabbit hole on that. So cerebral palsy is classified by the area of dysfunction. So either quadriplegia or diplegia. Quadriplegia, all 4 limbs. Diplegia, the lower extremities. The 3 major groups of CP, we have a spastic CP, which is the most common, 65 to 75% of cases. The motor cortex is the area of damage. There are pyramidal tracts as well. We're going to have a mix of paralysis, hyperreflexia, and increased muscle tone. Dyskinetic, 20 to 25% of cases. The basal nuclei in the brain and extrapyramidal tracts, loss of control and coordination. And these kids have either athetoid or coriform movements. Athetoid movements are slow, involuntary, writhing type movements, and the coriform are more rapid, jerky type movements. Ataxic type of CP. This is going to the area of the brain that damages the cerebellum now, and lots of gait impairments and loss of balance with it. Roughly 13% of cases are just a mix of them all, and there's going to be a smattering of symptoms that come from that. Other impairments could include some sort of intellectual dysfunction. 1/3 of the case have no impairment intellectually whatsoever. 1/3 have mild, and 1/3 have severely cognitive impairments with it. There might be communication and speech impairments, seizures, and other visual impairments as well.
And I just wanted to add, this is another one of these diagnoses where, because of how a person presents physically, 1/3 of cases of people who have CP do not have intellectual function impairments, but it can be assumed by others that they do because of their uncoordinated movements and how they present physically. And so that's an area that occupational therapy can address, just in how a person might navigate that challenge around being constantly misunderstood. And imagine if everyone you came across assumed that you had intellectual impairment, but you didn't.
Right.
So that's something that occupational therapy could address.
So some of the treatment, again, each case is unique, so the treatment of it would be unique as well. With the team of providers would be specific to that person as well. The rehab medicine focuses on reaching that next developmental milestone. The developmental milestones: sit independently, crawl, walk, run, throw a ball, catch a ball. Feeding independently is a big one, especially for dressing independently. All of those things are really important for families to improve upon, because I need a new term, maybe you know a better term, but it decreases, the term is burden of care. I want a different term for that, but it's a lot of work to feed a baby, 3, 4, 5 meals a day, depending on their growth spurts. And if the child can all of a sudden learn how to feed themselves, that alleviates a lot of time and energy for the caregivers to get freed up from. So, reaching that next developmental milestone, really important. Promoting strength, independence, coordination, potentially ordering equipment, assisted devices, environmental adaptations, really specific to the person here. One thing I will say, because with cerebral palsy, we're talking with kids. I mean, these kids are going to get interventions as early as 3 years old, or sometimes prior to, and can have interventions over the course of their lifetime. But when we're talking about kids, it's really important. And as you can see with this picture here, you got to make the treatment fun. If the treatment's not fun, the kid's not going to do it, and you're not going to get anything out of it. So the pediatric therapists in the world, like my wife, my wife jokingly says, I'll ask, hey, babe, how was your day? She'll say, I just played tic-tac-toe all day, or I just played hopscotch all day. Like, there's a real gift in being able to have fun with your treatments and still get something therapeutic out of it, and build towards the next things that we want. But it is a lot of fun. And if we look at just this picture of this pediatric clinic, I mean, look at that exercise they're doing: core strength, coordination, reaching. And I don't know if they're doing maybe a matching game, match the colors of the rings to the color of the cone. And just look at the overall environment. Like, you've got mats, you got block, you got all sorts of toys. Like, pediatric clinics are a fun place to be. And they should be. All right, next up, we'll talk about our seizure disorders. So, when you and I were talking, epilepsy was the term that we would throw around a lot. But epilepsy is kind of an older term and not used much because of the stigma that's attached to it. And I think that's the case with a lot of things in medicine. There's a lot of terms in medicine that at one point were okay to use, and we grow out of it because of stigmas or other problems associated with it, or we learn more, or one disease, we lumped it as one disease, but really it's several different disorders, sub disorders that are all kind of similar to one another. So I think with all of our textbooks, I mean, our medicine is constantly changing, and I think we should be sensitive to that, understand it, and then in 8 years there might be a new language than we're learning and teaching today, and we should be able to adapt to it. But anyway, so epilepsy is probably a term that more people are familiar with than just the group of seizure disorders, but that we'll keep calling it seizure disorders. Seizures are a result of uncontrolled excessive discharge of neurons, can be localized or generalized. 3 to 6 million Americans are affected by seizure disorders. Onset of greater than 75% of cases occurs before 20 years old. So it starts in the early life. Sudden, spontaneous, uncontrolled depolarization of neurons, go back to the action potential of the nervous system in the anatomy review if you need more context to that. That uncontrolled depolarization of neurons causes abnormal motor or sensory activity, possibly loss of consciousness. Neurons with seizure disorders are hyperexcitable, so that means they have a lower threshold for stimulation for some reason. Any physiologic change like alkalosis, temporary stimulus, or a sensory stimulus like flashing lights or a beating of a sound can activate these, what's termed as irritable neurons. And then the irritable neurons excite the neurons around it, and that causes that seizure. Can last for a few seconds or a few minutes. There's a few different types we'll talk about in a little bit. Different type testing like EEGs can help determine the type and size of this focus of the seizure. Categorized as generalized, which include both hemispheres and with loss of consciousness, or partial, where it's just a small area of the brain or smaller area of the brain without loss of consciousness. Most of the disorders are idiopathic. What does idiopathic mean?
Means that we don't know where it came from or why.
Yep, but there are some sort of genes that have been identified. 4 different ones have a role. Family incidents are also more common in younger children. Other disorders have a higher risk of seizure disorders like CP. But it could also be secondary or acquired seizure disorder. Might be the result of infection or injury. We had some sort of infection. That infection created these irritable nerves, and then all of a sudden they're ultra excitable, and we then develop a seizure disorder after that. This is happening more and more often because more and more people are surviving more serious brain injuries and infections. So we will be seeing more seizure disorders throughout our careers than the prior generations of massage, PT, and OT had to consider. Other seizures can be from tumors, hemorrhage, high fever, renal failure, hypoglycemia, sudden withdrawal of alcohol, or other use of drugs like cocaine. Any additional details on that, Christine?
Just that it's important to know that just because somebody has had a seizure or a couple of seizures, it doesn't mean that they have a seizure disorder. So, for example, if they have a seizure because of a high fever or as a reaction to a medication, that they may not have a seizure disorder. There's in order to be diagnosed with a seizure disorder, you have to have a certain number of seizures within a certain amount of time to have a disorder.
Right. So the signs and symptoms, again, we have generalized and partial. Generalized have 2 main subtypes, a petit mal, which or absence seizures. So more common in children beginning at 5 years old, last 5 to 10 seconds, can occur many times throughout the day, might appear as a brief loss of awareness, facial movements, or just simply staring into space. And the kids that I know who have seizure disorders, that's the most common display of a seizure, is just they're conscious, but they're just looking off into nothing for a while, and you can wave in front of them and they're not there right now.
If it begins around 5 years old, I imagine it might be challenging to realize that something like that's going on and
Definitely.
to get diagnosed, because you might just think they're ignoring you, or I imagine that would be difficult.
Yeah, I mean, with some kids, if they're watching TV, they can have that type of like, hey, kid, like, pay attention to me, and they're just so locked in.
Yeah.
Yeah, it can be really tough to discover. No memory of the episode is retained with these petit malls. Grand mal seizures or tonic-clonic seizures occur spontaneously or sometimes after simple seizures. The typical pattern are the predetermined signs, the prodromal signs: nausea, muscle twitching, irritability, again, nervous system irritability, not just getting irritated quickly, or depression hours before the seizure. An aura, a peculiar vision or auditory sensation immediately preceding the loss of consciousness.
And that's actually the aura that can be a part of intervention, is teaching people to recognize the aura and then showing them some safety techniques that they can take to prevent injury when they know a seizure is coming.
Right.
So that's a good thing to have an aura.
Yeah. So after the aura, loss of consciousness, tonic muscle contractions, a cry can escape as the thoracic muscles contract and force air out. Respiration then ceases for a brief moment in time. Clonic stage, where the muscles alternatively contract and relax. Increased salivation, bowel and bladder incontinence might occur during this time. Contractions gradually subside over the course of minutes and consciousness returns. The postical period is the remaining confusion, fatigue, and muscle ache after the seizure, along with a deep sleep. Now, a person can typically recall the prodromal signs and the aura, but not the rest of the episode.
So, and I'd like to add too that, with in the clonic stage, things to consider in terms of safety is that with the muscle contracting, they may be banging their head backwards. They could get a brain injury. They might be like gnashing their jaw or opening and closing it and bite their tongue. So there can be blood. They can bite the inside of their mouth, and they could choke on that blood. So you want to put them in a position on their side. Never put anything in their mouth, because they could bite at whatever it is and choke on that. So you want to prevent choking. And then in the postictal period, just to be aware of when somebody comes out of a grand mal seizure and they don't recall anything but maybe the prodromal signs and the aura, they may not know where they are. They may have confusion. They may not know how old they are. So you can't expect a person who just had a grand mal seizure to get up and let's keep going. You want to give them some time, and it can take a long time for them to feel safe and fully aware again. So you really want to move slowly and be empathetic to what the experience might be like for that person coming out of that seizure.
Yeah. So the other category are partial seizures, also known as simple seizures or focal seizures, manifested by repeated motor activity, a jerking of head or leg, or by altered sensations such like tingling that begins in one area, then spreads. Could have auditory or visual disturbances. Again, depending on the area of the brain would be where the problem, what the physical symptoms might be. So the treatments of it: anti-convulsant drugs, maybe sedatives. Lots of different side effects of medications, including gingival hyperplasia, that's the gums really growing out of control, reduced leukocyte counts, which is going to increase infection risks, decrease blood clotting capability. Sudden withdrawal of these medications can also cause either more severe seizures or this status epilepticus, which is prolonged or repeated seizures, and the risk of the prolonged or multiple seizures in a row is that it can cause more brain damage. So for us in the rehab world, we have to be aware of triggers. So there's different electrical stimulations that as modalities we can use that could be a trigger. Phototherapies, again, modalities that we could use that would be a trigger of these. Flickering lights, maybe even just the overhead light just needs, the bulb needs to be replaced. Just that flickering of that light could be enough of it. We also have to weigh the side effects of those medications when we're considering the treatment. Just a good example is the reduced blood clotting ability is going to be a precaution or maybe even a contraindication for different types of massage strokes and the pressures. We want to really be aware of that and weigh what are the pros versus the cons. Next up, we'll tackle dementia. Christine, do you want to take the lead on this one?
I'll give you a break. All right, so dementia, there's several different types of dementia. Typically, dementia follows a progressive pathway. So it's a chronic disease. Cortical function is decreased. That can impair the cognitive skills. So language, numeracy, logical thinking, judgment, ability to learn, motor coordination, the things that we talked about when we were looking at the lobes of the brain. Loss of memory, primarily short term, but there can be challenges with long-term memory. Memory loss is progressive, and not just memory loss, but cognitive function with dementia. It is typically lost in the reverse order that it was gained. And so when we're talking about developmental milestones of pediatrics, when the short-term memory develop, eventually executive functions where you're able to be organized and problem solving, pay attention, things like that. Those things come later in development, but they're the first to struggle with the progression of dementia. So typically short-term memory will be lost before long-term memory. Then there can be behavioral and personality changes, and that can be especially challenging for family and caregivers because they start to feel like they're losing this person, but they're still right in front of them, and they don't recognize the personality of the person as much anymore. Right. There are different tests that can be used to determine the memory loss versus normal forgetfulness, and that's in making an initial diagnosis. There's a person without dementia, they may be able to recall information, they'll be able to recall information when given clues. A person with dementia past a certain stage of dementia, they won't be able to recall even when they're given clues, but that's after a certain stage. Calculations can be difficult for them, and they may need reminders for meals and hygiene, things like that. So types of dementia, we have Alzheimer's disease. So that's the one that's the most common, and we're going to focus on that class for this class. And then vascular dementia is the second most common type. It's caused by cerebrovascular disease, and it can be the result of multiple small brain infarctions. Creutzfeldt-Jakob disease. So that one's more rare. It rapidly progresses and it's caused by an infection. And then the acquired immunodeficiency syndrome or AIDS dementia, and that's the later stages of AIDS, and the virus invades the brain tissue. So that can lead to loss of memory, cognitive ability, and impaired motor function. So Alzheimer's disease, it affects about 10% of the population over 65 years old and 25% of the population over 85 years old. It affects more females than males. The pathophysiology of Alzheimer's is that it's a progressive cortical atrophy. So that leads to dilated ventricles and widening of the sulci. So the senile plaques found in the affected parts of the brain that disrupt neural conduction. Again, that's how the neurons are communicating with each other, and that is what is interrupted. There's also a deficit of the neurotransmitter acetylcholine in the brain. And so there isn't a single diagnostic test available to test for that. A lot of the tests for dementia are testing to determine what stage or level the person is at in the progression. The etiology is unknown or idiopathic. There are 4 defective genes on different chromosomes that have been associated with Alzheimer's. Other suspected factors can be exposure to metals, viruses, and metabolic syndromes.
Christina, exposure to metals, I think it refers to things like lead poisoning, not metal music. I don't know why you put this Metallica cover album on. It's physical metals, exposure to physical metals, not the music genre metal music.
Oh, so there haven't been studies of people after they've gone to Metallica concerts?
I don't think that's what they're referring to, no.
Oh, all right. Thanks for the clarification.
No problem.
So signs and symptoms and the treatment of Alzheimer's disease. So the signs and symptoms, there's an insidious onset. It can extend 10 to 20 years, but average survival is 7 years after diagnosis. So this Alzheimer's disease progresses very quickly compared to some other types of dementia. So in the early stages, there's a gradual loss of memory, lack of concentration. This might look like, where did I put my wallet? I thought I had it when I was at the bank, and then you're driving around retracing steps to help the person find, but they're frequently losing and misplacing things. Ability to learn new information is impaired. And that's something that's really important to consider when you're working with someone with occupational physical therapy. Let's say they aren't able to learn new information, but now they need a walker. And physically, they have the balance to be able to use a rollator or a 4-wheeled walker, but they'd have to be able to learn how to safely use the brakes and the seat on it. Right. But if they aren't able to learn new information, then it's going to be a lot harder to safely teach them how to use that 4-wheel walker, and you're going to be a lot safer with a 2-wheel walker.
Yeah, and we also have to try to predict the future too. So if they, average age of survival is 7 years after diagnosis, but it's up to 20 years, what are they going to need potentially in 5 to 10 years? Not necessarily what do they need today. So it might just be wiser to go with, all right, let's start learning how to use this assistive device that I think they're going to need in 10 years.
Yeah, exactly. Teaching them while they're cognitively still able to learn.
Yeah, even if they don't need a walker right now, maybe we just start using it now while they have an ability to learn, because in 5 to 10 years, when they finally need it physically, cognitively, they're not going to be able to learn it. Yeah, it's a real challenge.
If they're right on that cusp of maybe they need it, not really, but they're almost there, you might as well teach them. Their reasoning and judgment in this early stage can be impaired, and this can start to create challenges around safety. This stage is where it can start to be questionable about driving, but their reasoning and judgment is impaired, then they may not be recognizing that they're not performing as well with driving. So they may need support in making that decision about whether to continue to drive. Behavioral changes like irritability, hostility, mood swings are common. And if you think about why, that could be because of changes to the actual brain. But it could also be, imagine you have the lived experience of you're starting to lose your cognitive function, and you can't find anything you're looking for. You're forgetting things. That can be really scary, and people will start to become irritable and have mood swings related just to that and to the fear of losing their independence. They can also, at this stage, it's common that people try to hide and compensate so that others don't take their independence from them. Then the progressive changes are more limited cognitive function, more decline in memory. And again, there's a lot of different types of memory. So you can lose short-term memory before long-term memory, working memory, things like that. Declining language skills, limited math ability, and poor judgment. So that might be when they need some support with managing their finances, managing medications, keeping track of when they take medications, apathy and indifference, confusion, managing ADLs, so dressing and things like that. When's the last time they took a bath? You might notice that they're not combing their hair. Wandering can become common and may become confused or lost in familiar environments. That's when it really starts to progress, and that's when you need to have safety mechanisms in place to prevent, even in that you have to know codes to get into a memory unit at a skilled nursing facility, because someone might just wander outside in the winter and freeze to death. And then the late stage, a person doesn't recognize their family, they lack awareness or interest in the environment. So even having any kind of sensory reaction can be difficult, and they become unable to function in any way. And we're going to move on to treatment. But at this late stage, a lot of the time, what we want to do is we're looking at positioning in bed and how we prevent some of those contractures like we looked at with stroke. If they're not using their limbs, then they might get these contractures in this flexor synergy pattern. And again, their caregivers are having to do everything for them, bathe them, dress them, protect their skin. And it's a lot harder to work with someone when they're kind of locked up in this fetal position. So it's every day educating the caregivers on how to do the range of motion with them to make it so that you can still move their body. So in terms of treatment, there is no medical treatment that can reverse Alzheimer's disease. Some medication can be used for issues like depression or anxiety, which is common. Many drugs are contraindicated because they can add to more mental confusion. It can be really helpful to maintain the same daily routine. That's a really good compensatory approach, because people, they can maintain their long-term memory for a long time, and they'll be able to remember how to get around or different things with their routine, how to do things that are familiar from their long-term memory. And then moderate stimulation like adult daycare can help to slow the progression as well, just having that stimulation. Rehabilitative medicine, so exercise is recommended, using a team approach and looking at how can we prolong that independent function. So looking at using different compensatory and adaptive approaches for occupational therapy. And then safety is a huge consideration, especially when they're wandering, and environmental changes to maximize the safety.
Yeah, different things like, video cameras, baby cameras. There's a whole host of things, fall alert bracelets and necklaces. There's a whole bunch of technology we get to use to improve this function and, long-lasting independent function if we can.
Sometimes even disguising exits. So I've seen a wall with a door on it, wallpapered like it's a bookshelf, but the wallpaper goes even over the door. So they're not realizing necessarily that there's a door there.
That's a cool idea. I've seen the opposite in Roadrunner cartoons. When the
Right.
when Wile E. Coyote was chasing after the Roadrunner, the Roadrunner would paint like a tunnel, but it wasn't a tunnel. It was just a boulder.
Yeah, that would be the opposite approach. There is
Yeah.
actually one approach that is not used anymore, I hope, but for a while it's what people used to prevent. It's called elopement, when someone will leave and if they're wandering, is they would put a black mat in front of the door. Because of the visual perception challenges, a lot of the time the person who has dementia would think that that was a hole.
Oh,
And so they would not want to go near the door because they thought that that was a hole. But imagine the anxiety that you would feel if there was suddenly a giant hole in front of your door.
yeah.
And so that was something that was considered to be inhumane.
Yeah. All right. Next up, we'll talk about Parkinson's disease. Progressive degenerative disorder affects motor function through the loss of extrapyramidal activity. About 60,000 people are diagnosed with Parkinson's each year. Roughly 1 million Americans have Parkinson's right now. So it's a progressive degeneration, changes in the basal cell nuclei, basal nuclei, particularly the substantia nigra, which causes the decrease in dopamine secretion. Dopamine is an inhibitory neurotransmitter, so there's an imbalance between excitement and inhibition. The excess excitation increases muscle tone, causes resting tremors, increases muscular rigidity, difficult initiating movement, and postural instability. The physical manifestations and the history are used to diagnose. So again, no one test is saying is testing for this, but it's a more of a collection of the physical symptoms that are presenting. Primary Parkinson's is idiopathic, develops after 60 years old, occurs both in men and women. Some genes have been identified as familial causes of Parkinson's, but some toxins, such as pesticides, could also be a cause. Secondary Parkinson's can follow encephalitis, which is inflammation of the brain, trauma or vascular disease, drug-induced Parkinson's, particularly antipsychotic drugs, can be reversed if the drug is discontinued. Signs and symptoms. So this is one of those conditions that once you learn about it, once you see it once or twice, this is a spotted across the room type of a condition. The very, very classic, everybody with Parkinson's basically looks like this. So early signs include fatigue, muscle weakness, aching, decreased flexibility. So, man, those sounds like reasons why someone would seek massage therapy or physical therapy or occupational therapy, right? Muscle weakness, aching, decreased flexibility. We might be getting people off the street in any one of our professions for these kind of complaints. Mm-hmm. Diminished facial expressions are sometimes more of a subtle change that definitely happens, but sometimes subtle in the early stages. More obvious signs include pill rolling type of tremors in the hands, more muscle rigidity as the symptoms progress. Bradykinesia, do you know what that is?
Bradykinesia is slow movement.
Slow movement, yep. Lack of
medical terminology told me that.
Nice. It must be a good class taught by good people. Lack of associated involuntary muscle movements. So that's the reciprocal arm and leg swing. So if I take a step with my left leg, my right arm should swing with it. And then, I keep going like that. So when it's the lack of associated, so we're not going to be swinging that contralateral limb. Stooped posture with a festinating gait. A festinating gait is short steps with almost an acceleration to it. We'll see a video of that just shortly. Voice becomes low and devoid of inflection. Chewing and swallowing becomes difficult. Flat affect also becomes more apparent. Again, flat affect is more of that lack of facial expression. And orthostatic hypotension can develop, urinary retention and constipation can develop, which increases the risk of urinary tract infection. Also, increased risk of respiratory infection in the later stages. Dementia can develop in roughly 20% of cases. So I do like this picture. It kind of shows us a lot statically. I want to show.
Do you ever recognize the symptoms of Parkinson's outside of work? Like I have a neighbor who walks his dog right now, and I don't know him, but when I see him by, I think, I wonder if he has Parkinson's and if he knows.
Yeah, definitely. Yep. All right, so I just wanted to show this video. Christine, is the video showing on your end?
Yes.
All right, perfect. So mild to moderate Parkinson's disease, we can see the reduced arm swing, that stooped posture, some path imbalances, not walking in a completely straight line. See that? I mean, that reduced arm swing and trunk motion, that stooped posture, that just stands right out to me. The shuffling steps is going to be more obvious in this person, these next few people. There we go. There's the decreased step length, little slower. I don't know what profession this person is that's testing this person, but I like that they're using a gait belt and then just not even, they're physically not ready to help whatsoever. I think we need to, come on, we're taking a video here, at least pretend. Here's a dual task event.
Oh, that turn. Yeah, you can really see.
Yeah, that turn is the classic. I mean, they're turning almost like on a pedestal. This dual task, he's got to carry this tray. So that's taking some cognition away. He's going to have some freezing episodes. So now he's stuck, right? His brain is telling him to take a step, but his body's not responding to it. And now, man, those really short steps. So really classic movement pattern. Of that Parkinsonian gait. So some treatment of it, well, we can do a lot of different medications to improve the dopamine production and uptake. Dopamine replacement therapy, levodopa is the most common right now form of treatment, although there are a whole host of different medicines. There's also a lot of side effects to medicine, so it's a real taxing effort to determine not only the correct medication, but also the correct amount and dosage of the medication. One other thing with a lot of the dopamine replacement drugs is that there's a 10 to 15-ish year shelf life that you can use some of those medications for. So that might be great for the next 10 years, but eventually you're not going to be able to use them again. So when do you start those medications can be a really tough problem, especially for someone who's diagnosed. I'm seeing more and more younger people diagnosed in 40s and 50s. So if we're only going to have a 10-year life of these medications, man, we've really got to figure out when do we start them. So there's a lot of different rehabilitative medicine that we can use for this. So focus on it to improve overall mobility. Powerful exercises is the most, as far as exercise goes, some of the most beneficial. So the Big and Loud program, LSVT, Big and Loud program for both physical and speech. That really helps. A lot of explosive, gigantic movements. Boxing, there's a lot of boxing. There's Parkinson's only boxing gym in East Greenwich. Rock Steady, I think, is the name of the one in East Greenwich. They do fantastic job here. Now, this picture of the boxing is fantastic, but man, look at that guy's face. That is the flat affect that we're talking about, right? I mean, that guy is exerting a lot of effort. Hopefully he's having a little bit of fun, but you almost can't see if he's happy, sad. Like there's almost no emotion on his face. That's what that flat affect refers to. We can also just keep working on coordination, use of assistive devices, depending on severity stage and individual problems that that person might have. And you also have some knowledge on the use of rhythmic auditory stimulation. What is that?
Yeah, so that's something that I've used before, and it helps with movement control. So, and also preventing falls. So 50% of people who have Parkinson's experience recurrent falls. And with an increase in dopamine, there's an increase in voluntary movement. So with voluntary movement, if you think back to the freezing that we saw in the video that you just showed of the Parkinsonian gait, where he was freezing and unable to, you could tell he wanted to move the leg and couldn't, he didn't have that voluntary movement. And so looking at the timing of movement, that's what's actually disrupted. And there's explicit timing. So explicit timing, and this is the challenge with Parkinson's disease, is that that's the internal and deliberate movement. So your brain is telling your body to move. It's voluntary, and that comes from the basal ganglia, and that's what's really being affected by Parkinson's disease. Then there's implicit timing, and implicit timing comes from external cues, and it's less conscious. And so that comes mainly from the cerebellum. And what rhythmic auditory stimulation does is it uses music, the beat of music or a song or a metronome, as the external cue to help with the rhythmic movement and the timing of it. So you will literally see, if you teach someone how to pay attention to the beat of the music, and you can look at the cadence of the beat of the music, and if they can learn to sequence that with their steps, they'll have less of that freezing and more natural stride lengths and things like that. So that can be really helpful. It's called rhythmic auditory stimulation. And I worked on that with patients where I taught almost like we were doing a dance and learning steps to a song. There'd be a specific song to practice safely doing a functional transfer.
And if you click on the link, you students can see an example of that too. Pretty cool to watch. All right, next up, Huntington's disease. Pretty rare disorder, progressive, hereditary, degenerative diseases, affects to roughly 1 to 20,000 people worldwide, a little bit more common in the United States. It's a progressive brain atrophy, degeneration of neurons, particularly in the basal ganglia and the frontal cortex. Basal ganglia is a group of nuclei responsible for the motor control, motor learning, executive functions, behavior, and emotions, especially. And the frontal lobe, like we talked about earlier, voluntary movement, expressive language, high-level executive functions, and planning. So the etiology, it's an autosomal dominant hereditary disease located on the 4th chromosome. Gene causes production of abnormally long protein that breaks into segments, coagulates, and builds up in the neurons of the brain. The longer the protein, the earlier the onset. So typically the onset is somewhere in the 30s and 40s, progresses fairly slowly. Initial symptoms are similar to Parkinson's. Several movement disorders are also chorea, dystonia, myoclonus, and movement tics. Some hallucinations might also be present, along with sleep changes, aggression, poor concentration, and severe mood swings and seizures. And it's the aggression, it's the aggression and mood swings that sometimes can be the most challenging for us to work with, and also families to be coping with. Cannot be cured, and the mortality is somewhere 10 to 30 years after the onset of symptoms. No medications for the disease, but there are some medications to manage individual symptoms. So can we prevent mood swings and seizures with some of these other medications? Now, our physical interventions need more research on effectiveness of interventions, along with the timing of the services, when, early, late, when should we be intervening. But focus should be on maintaining functional independence, as well as fall prevention and ambulation strategies. And again, I just want to say the behavioral changes, the aggression, mood swings are some of the most challenging and unpredictable aspects of this disease. And we have to watch our safety of not only ourselves as we work with somebody with this, but also of their loved ones who are also the caregivers.
Why are we learning about Huntington's?
Boy, that's a great question. There's a lot of things like the traumatic brain injuries, strokes, cerebral palsy, Parkinson's. We're going to see those in our career. I don't care where we're going to be. But there's a million different types of diseases out there. And what we should hopefully have is just the ability to learn new things and also apply what we know from a similar disorder and maybe apply it to what this condition is. So by learning just this brief time about Huntington's, if the initial symptoms are similar to Parkinson's, what do you think the treatments off the top of your head should be similar to?
Mm-hmm.
Parkinson's, let's use that as our foundation and build from there. And then as clinical-based problem solvers in the PT, OT, and massage worlds, we can then adjust our treatments down the road as we see, but at least it gives us a starting point to not be afraid and say, well, nobody's ever taught me this. Well, we can't teach you everything. You have to take what you do know and apply it to a bunch of different things like you might. And there's a whole host of obscure diseases that nobody's ever heard of that you might be the first person that has to work with them and you just have to kind of start figuring it out.
And again, this is being familiar with the anatomy of the brain and, the Huntington's affects the basal ganglia. Well, I know that Parkinson's also involves the basal ganglia. So I know I have a sense of what that looks like.
Yep. Next up, spinal cord injuries. Spinal cord injury is a really important one for us to talk about. Around 11,000 Americans experience spinal cord injuries each year. 200,000 have ongoing disability from a spinal cord injury. Most occur in the cervical spine, C1 to C7, and then the lower thoracic to lumbar, T12 to L2. Mechanisms, a lot of different mechanisms to it. Hyperflexion or hyperextension of the cervical spine. Dislocation of a vertebra, compression fracture, or penetration injuries like a stab wound or a bullet wound are all common ones. So what happens? So the damage to the spinal cord could be temporary or permanent. Axons of the nerves might have some regrowth, similar to what we talked about in peripheral nerve injuries way back in the beginning of this presentation. Complete severing or crushing of the spinal cord will cause irreversible loss of all sensory and motor functions at that level and below. If you refer back to the dermatome map that we talked about in the anatomy review, then that will help give you kind of a visual of what we mean by at that spinal level and below. Partial transection or crushing injuries might allow for some recovery. Bruising might occur and damage is reversible once the edema is resolved. So any swelling must be resolved quickly because it can it will display injury levels above or below. So the swelling of the around the spinal cord will make the injury look much more severe, much bigger than it is. So we need to resolve that to see what the actual effects are. Damage to the upper cervical spine, C3 through 5 can interfere with the phrenic nerve innervation to the diaphragm. So now we're going to affect breathing because of that. The initial period after a spinal cord injury is known as spinal shock, where conduction of impulses ceases into the nerve tracts. As inflammation subsides, reflex activity in the spinal cord can resume, and in the spinal cord at level below the injury of any undamaged tracts. So most spinal cord injuries occur in younger men, average age is 38 years old. 50% are a result of motorcycle or automobile accidents. Second most common mechanism injury is in sports, and falls, particularly in the older adults, is the other primary cause. Now, what are the signs and symptoms? Well, the first stage is spinal shock. That occurs the first few days or weeks after injury. All neurological activity at and below that level of injury ceases. No reflexes are present, including skeletal muscle, sensory, and autonomic, which is bowel and bladder function. Patients with cervical injury might also have loss of vasomotor tone, blood pressure changes, diaphoresis, body temperature, bowel, and bladder emptying impairments. We'll also see that flaccid paralysis as well. The second stage is recovery from that spinal shock, and that is a gradual process. Gradual turn of reflexes at the level below the level of injury. No impulse or reflexes can go through that site, but if it's a spinal reflex, then that can still work. Most cases develop hyperreflexia. So that's an increase in those spinal reflexes. That's because there's some dampening effects. And again, this goes back to knowing the tracks of the spinal cord. There's some inhibitory activity that happens with this. And if those inhibitory signals can't reach it, then we're just going to have hyperreflexia because of that. We could also have that spastic paralysis, similar to what we saw in the strokes that we talked about. Neurogenic bowel and bladder function gradually will reveal what permanent damage exists once we keep recovering from that spinal shock. A couple important terms: tetraplegia, also known as quadriplegia. That's paralysis including all four limbs. Paraplegia is just the lower extremities, the lower part of trunk and limbs. Important to note the sexual and reproductive function. So for males, we could have neurogenic reflex erections, but sustaining those erections can be difficult. High-level injuries can also cause infertility because sperm production in the testes becomes impaired. For females, women usually resume their menstrual cycle once the acute trauma resolves. Women who have spinal cord injuries can still have children, but requires close monitoring because it's a higher risk pregnancy, and especially if there's sensory changes in that woman, then that can cause some complications. Vaginal delivery might be difficult though for that. Some different types of spinal cord injuries. So this is where spinal cord injury gets a little crazy. When we start talking about incomplete spinal cord injuries, then we have to really understand, okay, which section of the spinal cord is the injured piece of this. So in Brown-Séquard's spinal cord injury, that's an incomplete lesion due to a stab wound. It's going to have ipsilateral symptoms of paralysis and loss of position sense and vibration due to the corticospinal and dorsal columns impairments. Contralateral symptoms of loss of pain and temperature due to damage of the spinal thalamic tract. Anterior cord spinal injury is resulting from a compression damage to the anterior aspects of the spinal cord, typically in the cervical flexion. Loss of motor function, pain, temperature sense below the lesion due to the damage of the corticospinal and the spinal thalamic tracts. Central cord is compression damage to the center of the spinal cord, typically a hyperextension injury that damages the spinal thalamic tracts, corticospinal tract, and dorsal columns. The upper extremities is an interesting piece of the central cord. The upper extremities might present with greater involvement than the lower extremities. So that's a really unique symptom of the central cord. And the motor deficits are greater than sensory deficits. And again, all this has to do with the anatomy of the spinal cord. Posterior cord, relatively rare loss of pain, proprioception, 2-point discrimination, and stereognosis, but motor function is preserved. And then quada equina injury, that's a spinal cord injury at the level below L1. That's where the spinal cord starts fraying apart. Pretty much considered a peripheral nerve injury, but characteristics include flaccidity, areflexia, and then impairment of bowel and bladder function. And here's some visual demonstrations of what each of those might look like. So treatment of spinal cord injuries, well, first the treatment begins at the time of injury, care to immobilize the spine, maintain breathing, prevent shock, prevent additional injury. Traction and surgery might be required to relieve some pressure or potentially repair tissue. Medications to reduce the edema and reduce the and stabilize the vascular system. The rehab team comprised of definitely PT, OT, psychotherapists, maybe respiratory therapists for the cervical injuries. But the goal is to assist the patient in performance of ADLs, decide what the best assisted devices are needed, prevent future complications like skin breakdown, pneumonia, urinary tract complications, and musculoskeletal injury issues. Any other treatments that you can think of? We'll talk about autonomic dysreflexia next, but any other treatments, just broadly speaking?
So from an occupational therapy perspective, there's a lot of different equipment, adaptive equipment that can be used to help people manage utensils, to be able to pick things up, to assist with their grasp. There can also be some positioning, looking at positioning in their, maybe in their wheelchair if they need, if they don't have the trunk control to stay upright, maybe they need a strap. Looking at just ways to increase their independence. How can we adapt activities like we've talked about, but then looking at how can you connect a person with the community of other people who have spinal cord injuries, because there's a lot of really cool stuff out there that's happening for people who have spinal cord injuries, and there are a lot of things that people are accomplishing. And so there's programs where people can go away to camps where they're doing surfing and kayaking. And in those same programs, they get to talk with other people and learn about, just for the peer support piece of it, what are some strategies that they use for doing their bowel and bladder programs. And to be able to have those conversations with peers is very powerful. So getting people connected with community in terms of feeling a sense of belonging with others. And then also looking at maybe adaptive sports. There's wheelchair basketball, there's adaptive skiing. There are a lot of different adaptive sports. And then looking at wheelchair skills, advanced wheelchair skills. So if they're going to be wheelchair bound in a manual wheelchair, you can teach them how to hop up onto curbs and things like that, so that they can be able to navigate their environment more independently.
Even with wheelchairs, there's a million different types of wheelchairs and different components of it. So yeah, the adapting the environment to the person and giving the appropriate set is a heck of a job in and of itself. Mm-hmm. So something that we really have to, if you've fallen asleep, wake up. Let's pay attention now. The important consideration with spinal cord injuries is something called autonomic dysreflexia. This is a life-threatening condition triggered by a sensory stimulus that causes a massive sympathetic reflex response that can't be controlled by the brain. So the trigger can be some sort of noxious stimulus, most oftentimes distended bladder, a kink in a catheter or something along those lines, or some sort of sensory stimulus below the level of injury. The level of injury has to be T6 or below.
It could be an ingrown toenail.
Yeah. The sympathetic nervous system response causes severe vasoconstriction, which causes a sudden increase in blood pressure, a drop in heart rate, excessive sweating above the level of the spinal cord injury. High risk of stroke and heart failure, and it must be resolved quickly. So remove the noxious stimulus and then medication to lower the blood pressure. Here's a little bit of a visual depiction of that.
So you're going to be watching for the person. Can you go back to the picture?
Yep.
You're going to be watching for the person to be sweating profusely. Maybe their skin is very flushed and they have a headache. And when you see that and you know that this is a possibility, that's when you have to act quickly.
Yeah, and it comes on all of a sudden. It's not we've been practicing transfers for the last 45 minutes and we're sweating because we're exercising. No, this is like a light switch happens and all of a sudden this just hits the person like a ton of bricks.
And it can be because they're, you know, getting the flu or something too.
Yeah. So our response, first, move the patient in the upright position, however upright we can get them. Why is that?
So if, let's say the person is in a wheelchair and it's a tilt in space wheelchair, so it tilts them backwards. If you think about the blood pressure, so autonomic dysreflexia is a sudden, rapid, intense increase in the blood pressure. So now the blood pressure is very, very high. And what do you do when somebody's blood pressure is low? So like being orthostatic, you want to raise their legs above their head to increase the blood pressure toward their heart. In autonomic dysreflexia, we want to do the exact opposite. Their blood pressure is too high. We want to make sure that their legs are below their head. So if they are tilted back in their wheelchair, you want to bring them upright. If they're lying down in the bed, you want to tilt the bed. You want to raise the head of the bed if they have a hospital bed and get them more into an upright position to help bring down the blood pressure. And then you're going to, right after that, you're going to check for the catheter to make sure there aren't any kinks in the line or blocks with the catheter. You're going to loosen any tight clothing. A lot of the time people can have abdominal binding. You're open the abdominal binding. Maybe it's a gait belt, something too tight and constricting, and you're going to call for help. This is a 911 or hospital code situation.
Yeah, if you're in the hospital, you press the button on the wall, you call for a code. Outside of that, you call 911. Christine, why don't you tackle spina bifida?
All right. So with spina bifida, there's a group of neural tube defects and they're congenital anomalies. There's different severities. So again, congenital means that it happens just prior to or during birth. So there's 1,500 to 2,000 out of 4 million live births per year in the US. It is slightly higher in Canada. I don't know why. With spina bifida, it can be certain vitamins during pregnancy that need to be taken. So that's part of why we have prenatal vitamins. So the pathophysiology, there's a failure of the posterior spinous process on the vertebrae to fuse during fetal development, and that's around the 4th week of development. So this failure to close, it permits the meninges or the spinal cord to herniate, and that causes a neurological impairment. So it's most commonly in the lumbar area. So there are 3 different types of spina bifida. There's spina bifida occulta. So that's when the spinous process does not fuse, but no meninges or spinal cord herniation exists. And then the defect can present as a dimple or a tuft of hair over the skin site on the lumbar spine. Then there's meningocele. So that includes herniation of the meninges and the cerebrospinal fluid, causing a sac on the surface of the skin. And the neurologic impairments aren't typically seen, but they can have neurological damage if the sac ruptures. So there's this visible sac. And then there's myelomeningocele. And this is when there's herniation of the spinal cord and the nerves with the meninges and the cerebrospinal fluid in the sac. So this is where there's a considerable neurological damage. So that one's the worst one. So spina bifida can be tested at weeks 16 to 18 of gestation with an amniocentesis. So this is when they take amniotic fluid and examine it. And it looks for the presence of alpha fetoprotein, and it leaked from the defect in the amniotic fluid. So that's how they test for that. So here's the spina bifida occulta, the meningocele, so you can see that sac, and then the myelomeningocele, so you see everything, it's protruding out. So the symptoms and treatment of spina bifida, so the etiology, so it's a combination of genetic, environmental factors, so that can be exposure to radiation, gestational diabetes, and then again, these supplements, vitamin A or folic acid deficiencies in the pregnant mother. Signs and symptoms, so again, it's that tuft of hair or protruding sac, depending on the type. The extent of neurological symptoms depends on the severity and the level of the deficit. The myelomeningocele has some degree of muscle weakness or paralysis, as well as sensory impairment at the level of dysfunction and below. And bowel and bladder control are usually impaired. And then the treatment is surgical repair of the deficit. So that can be done in utero or postnatally. And there's a danger of not having or delaying surgery because the sac could rupture, and that can lead to infection and other complications. And then rehabilitative medicine involves ongoing change depending on age and function of the child. So you're looking at reassessing as they develop what their needs are and treating them based on the changes as they develop. Managing the neurological symptoms, and then ordering equipment, managing equipment, and offering supportive services to families. So I worked in a group home with, he was a man who was in his 30s who had spina bifida, and he was wheelchair bound in a motor wheelchair. And we were always looking at doing transfers, but because of the paralysis that he had in his lower extremities, teaching him different, and he had contractures, so it wasn't your standard transfer. So being able to teach him how to do sliding board transfer, and then pressure relief techniques. So teaching him, because he didn't have any intellectual deficits, so he could learn on a schedule and with certain reminders to be able to use the arms of his wheelchair to lift up for some pressure relief techniques while he's in his wheelchair, and in terms of positioning. So there's some examples of how you might work with someone as an adult who has spina bifida. And then we have ALS, formerly known as Lou Gehrig's disease. So ALS is a progressive and degenerative disease. It affects both the upper motor neurons, so the cerebral cortex, and the lower motor neurons, which is the brainstem and the spinal cord. So the etiology is unknown, but there are some genetic components, and it does mainly occur between ages 40 and 60, and occurs more often in men than women.
So I'll just say these people, one, Stephen Hawking, another, the middle person is Steve Gleason. He played in the NFL for the Saints. And the other one is Peter Frates, who started the Ice Bucket Challenge to raise money for ALS. So those are those three people there.
So the pathophysiology of ALS, so the supportive glial cells called astrocytes, they secrete a neurotoxin, and it leads to the death of the motor neurons. The upper motor neuron loss leads to spastic paralysis and hyperreflexia, and the lower motor neuron damage causes flaccid paralysis and diminished reflexes. So the cognitive function remains intact, and so do sensory neurons and cranial nerves 3, 4, and 6 to the eye muscles. So the eye function will be preserved and the cognitive ability will be preserved, but then the loss of motor neurons is asymmetric in pattern. So there's a progressive weakness, and that eventually affects the respiratory function. And a lot of the time when people die from ALS, it's because of the impact on their respiratory function. So diagnosis is made by ruling out other conditions. So signs and symptoms and the prognosis. Signs and symptoms is muscle weakness, involuntary movements, spasticity, Symptoms progress to include atrophy and paralysis, fatigue, dysarthria and dysphagia, likely positive Babinski sign, hyperreflexia, and sensory systems remain intact. And then the prognosis is that symptoms progress over a 3 to 10 year period. But again, like I said, patients typically die due to respiratory failure. So one thing that can be challenging looking at the treatment of ALS, well, first they're going to rule out other diseases as the cause of the symptoms. That's how they come to the diagnosis. They will use medications to suppress muscle spasms, potentially ventilation once the disease progresses, if the person chooses to have that. But we're looking at their functional independence, keeping in mind that this is progressive, this disease. And it can be really hard to look at this and really give an honest opinion as to how the disease is going to progress. You want to look at how do you decrease pain, patient and caregiver education, home modifications, low-level aerobic exercise, eventually maybe chest PT. But an example I have is when I was working in home care, I had a patient who was diagnosed with ALS, and they wanted us to come in and look at home modifications and patient education around positioning and how the spouse could support the patient in positioning and being as functionally independent as possible. And they had in mind that they were putting in ramps, and they put in a Hoyer lift, like the track in the wall, in the bedroom to the bathroom, and they had a lot of equipment, but they were looking at voice-controlled environmental units. And to have the conversation with them that because of the effect on the diaphragm, the progression of disease is going to likely lead to the person not being able to communicate verbally, to use the voice control. So I had to educate them on using eye gaze technology, because that would not be affected in order to control their environment. And that can be really challenging to have those conversations. And then the other approach for occupational therapy in that particular situation was that the caregiver, the spouse, was the wife, and she was having emotionally a very hard time. You have to adapt really quickly to these changes. And every time you're going in to assess, then you have to, the new status, their functional status changes very quickly. So then you're assessing again. And how can the wife support the husband? And I taught her how to do the passive range of motion and massage to help control the edema in his hands, and how to position him in bed with his hands elevated to control the edema. And that eventually, toward the end, was how they connected on an intimate level in their relationship. And it became one of the most important parts of their daily ritual, is for her to essentially tuck him in and position him and do this massage and passive range of motion on his hands.
Yeah, well, what a beautiful story. And, our impact is far beyond just the patient in front of us. We have to consider all aspects of their life and all people involved. So, yeah.
Yeah.
All right, next up we'll tackle is Guillain-Barré. Guillain-Barré is precise cause unknown, likely some sort of autoimmune disease triggered by an infection that triggers an immune response, causes nerve demyelination and axon destruction that will repair as long as the cell body remains alive. It occurs in roughly 1 out of every 100,000 people. So in Rhode Island, we have right around 1 million people. So 10 people per year Rhode Islanders will come down with Guillain-Barré. I will say in 1 year, I had 3 people with Guillain-Barré all in the same calendar year. That was pretty crazy. I never had one before, and I haven't had one since. But yeah, in that 1 year, I had 3 people, 2 college-age girls and 1 50-something-year-old man. Anyway, Etiology occurs after an infection, most often a respiratory or GI infection. Unknown why some people have this response and others, why does it happen? We just don't know. Symptoms develop rapidly, tend to have greatest weakness at 3 weeks after onset of symptoms. Initial symptoms include weakness, tingling of lower extremities, and that spreads proximally. Symptoms are usually bilateral. Deep tender reflexes are absent. So the crazy, the great thing about Guillain-Barré is that it will resolve and it will improve. The tough thing is you have to get to the diagnosis quickly, because some people have do not resuscitates, living wills, end of life disorders, where if because the symptoms can mimic ALS, but it's Guillain-Barré, that we really have to get to a diagnosis quickly, and that's really tough. Prognosis, most people have full recovery, or at least close to full recovery, even if the symptoms are severe. And the symptoms can progress to the point where the patient needs to be on a ventilator, because that's the progressive weakness of it. And again, that decision-making of what do we do here is important. Recovery can take weeks to years. Roughly 2 to 3% of cases will result in death. Off the top of my head, the average recovery time for the 3 people I worked with that 1 year was about 6 months. Medical intervention, rule out other diseases, monitor symptoms and progression in the ICU if they need it. No known cure exists. For our physical medicine, range of motion, passive range of motion of all limbs initially, progressing at the rate of their nervous system recovery. So we're constantly changing what we're doing, because the person that we see the next visit is going to be different than what we last left them at. And that's really fun. Initially, if they are immobile for any length of time, prevention of DVTs, bed mobility, looking at transfers in gait, and then returning to optimal level of function. Both college-aged women, had 0 effects. The man went back to skiing. That I think I saw him in the summer, and he went back to skiing in that winter season with his family. He lost track of him shortly after he returned back to skiing, but his residual symptoms that he complained of is tightness in his lower back. That was his like the last symptom that hasn't subsided yet. So there. You want to take on multiple sclerosis, Christine?
Yeah. So with multiple sclerosis, it's a progressive. Remember, we talked about the myelination of the neurons. So progressive demyelination of neurons in the brain, spinal cord, and the cranial nerves. So there are a lot of different types of MS with considerable variation in the effects, the severity, and the progression. MS has periods of remission and exacerbation, but overall it is progressive. So there are times when people will feel worse, times when they'll feel better, but eventually it does progress typically. The estimated incidence is 30 to 100 per 100,000 people. And then it's the second most common cause of disability in the US, and that's behind motor vehicle accidents.
I will say there's a lot of good MS fundraisers. MS is the Multiple Sclerosis Society is a charity that's near and dear to my heart. My wife's, my father-in-law passed away due to MS. So if anybody ever wants to join the MS Walk Team, Bob's Beauties is a good one to join in and fundraise and keep contributing to the MS Society.
And then pathophysiology and etiology. So there's a loss of the myelin, and that interferes with the conduction of the nerve impulses. It occurs in diffuse patches throughout the nervous system. Early lesions occur as an inflammatory response. So research has identified a protein in the body's blood clotting mechanism as a potential trigger of the immune response. And that initial inflammation may subside and neural function may return until another exacerbation occurs. The severity can range from mild and slowly progressing to severe and rapidly progressing. The etiology, so the onset of symptoms occurs in people between 20 and 40 years old, but the peak is at 30 years old. More common in women than men by a 2-to-1 ratio. The exact cause is unknown, but it is believed to be autoimmune disorder with genetic and environmental components. It does occur more commonly in people of European descent and in more temperate climates, so northern US and Canada. The diagnosis is from exclusion of other conditions because there is not a definitive test for MS. So looking at the signs and symptoms and the treatment. So the signs and symptoms depend on the areas of demyelination in each person. So there can be vision changes. Those are the most common early signs. A lot of the time it's when people go to the eye doctor that they first have something recognized, some changes in the eye. And then the eye doctor will make the referral. And then weakness can begin in the legs, paresthesia if the sensory nerves are involved. And then the weakness can progress, extending into the upper limbs, and then can involve bowel and bladder dysfunction. And then later in the disease, depression or euphoria can develop. So for treatment, there is not a specific treatment available, but research is constant in discovering new approaches. Rehabilitative medicine. So we aim at improving the mobility, coordination, energy conservation, adapting the environment to the patient, and that's with consideration of the progressive nature of the disease. Prevention of respiratory infections, pressure ulcers, and contractures are important for later stages. So of particular concern, there's increased temperature can exacerbate MS symptoms. So it's important for all practitioners to understand and make adjustments. So if you're doing aquatic therapies, the room temperature, exercise-induced increase in body temperature, hot packs, hot yoga. It could be a hot summer if a person doesn't have air conditioning at home. So looking at how do you support that person in their energy conservation and managing these symptoms.
I had a student actually a few years ago. I was teaching pathophysiology and talking about MS, and she had MS. She was in her mid to late 20s. She had diagnosed a few years earlier. I said this, and she just blurts out, "Is that why I have such a problem with hot yoga?" She was very athletic, exercise all the time. Yoga was her primary choice. And anytime she did hot yoga, she said she would have an increase in her MS symptoms for 3 days after. And I was surprised that I taught her that in class. Like I just would have assumed that she would have had that knowledge being a few years, diagnosed a few years earlier. It wasn't new for her. It's just important that you can never educate your patient enough, and you can never just assume that they know.
Right.
I think they know what they're living with more than we know what they're living with, and we should understand the things that they talk about. But we should always be educating about the disease and the environment and things we're going to try to prevent and things we're going to try to promote and everything else. We should always be educating and don't assume that they just know because they have it.
And I would even go further to say, if you ask someone, do you know about the temperature, what a hot increased temperature can do to the MS? And if they just say yes, I would ask them to explain it to me, explain their understanding of it, because sometimes you can find out that somebody doesn't quite understand it, or they think they understand, but there's another way that you could open a conversation about it as part of your education.
Yeah.
And then another approach with MS that I've used a lot is around the energy conservation. So that's something that occupational therapy will tend to work on with people who have MS. And there's something that's called the spoon method. So the spoon method is the idea that you wake up each day, when you have MS, you wake up each day with a certain number of spoons full of energy. And there are different things that will tax the amount of energy that you have. So take away one of the spoons. Maybe if you didn't get a good sleep the night before, you're not going to wake up with as many spoons to start your day. And then there are certain things that you'll do throughout the day, like taking a shower and getting dressed. That might cost you a spoon, but maybe lying down and taking a nap in the air conditioning will help to give you back one of those spoons so you have more energy later. If you know, taking into account, that it's a really hot summer day, that's going to cost you a spoon on top of your typical commute to work, what that might cost you. So it just helps people to have a better sense of how rapidly they're going to lose energy and how they can manage their time and their efforts throughout the day.
Yeah, it's a really good concept to be aware of and educate our patients with.
Mm-hmm.
All right, Christine, so those are all the pathologies we want to cover for today. Any closing thoughts?
No. Do you have any closing thoughts? I never have closing thoughts.
Nope. Thanks for all of the information. I got to say, you got some nerve.
Thanks. I appreciate the compliment.
All right. Thank you so much.
Bye.